Hello, everybody. It's indeed a pleasure to come for this annual Avatar event. I thank Dr. Jasuja and his team for inviting me here. It's a lot of learning for all of us, not only for the nephrologist, but for a mere intensivist like me. So, today I would like to talk about blood purification, um, what Indian experience we have. Okay, so I bring you greetings from Vedanta, the Medicity, outskirts of Delhi, where I work. So, what is a cytokine storm? Basically, it's uncontrolled systemic inflammatory reaction to a variety of factors. It may be because of, most commonly, is bacterial or viral infection, or it may be because of certain systemic diseases like lupus or rheumatoid arthritis, and post-transplantation, it also can happen. What happens is either there are environmental factors, like what I said, including trauma and burns, certain allergic disorders, or host factors like malignancy and autoimmunity, which may initiate HLH or MAS or SIRS-like syndrome, which releases the inflammatory or anti-inflammatory cytokines, which are dysregulated, so it produces cytokine storm. And there may be certain common phenotypes which may be more likely to get into this. And there are certain pharmacological interventions, either maybe non-pharmacological like hemiabsorption or hyperbaric oxygen, or certain targeted which act at a particular site receptors like IL-6 receptor blockers or IL-1 receptor blockers, JAK inhibitors, or certain adjunctive therapy like immunonutrition and steroids and other drugs. And once the cytokine storm happens, it can affect virtually any organ of the body, starting from the brain to the intestine to the liver, kidneys, obviously lungs and heart are the other common sites, including endothelium and peripheral vascular tissues. So there are potential triggers, maybe the pathogen induced, like what you see in this COVID-19 virus, or it may be immunogenic induced. There are certain, obviously, CD4 and CD8 cells play an important role in initiation. Cytokine storm is initiated, pro-inflammatory cytokines are released initially, TNF alpha, IL-6, IL-8, IL-1. Interferon also play some role. There may be anti-inflammatory cytokines which may balance it out. JAK receptors also play a role. And then which way it goes depends on what is the balance between the two. So basically, it's a balance between pro and anti-inflammatory cytokines. So whether the patient goes into MODS and vasopagic shock, or the patient recovers, or sometimes the patient can have secondary bacterial sepsis. So what extracorporeal therapies, what they do, they restore physiology. They remove cytokines, they remove endotoxins, and restore the balance, physiological balance. They may remove certain toxins also. What are the features of particularly this cytosol filter, what we're talking about? Well, there are multiple beads, polymer-based technology. So they're size selective, so they absorb all the molecules between, say, 5 or 10 to 55 kilodaltons. So humongous surface area equivalent to 4 football fields, 45,000 square meters. It's a size selective approach and concentration dependent adsorption happens. It's very easy to set up. It works with every modality of dialysis. And the duration varies from 6 hours to 24 hours. It's been used basically to modulate the SIRS response, which may be in sepsis, or maybe in ARDS, burns, trauma, pancreatitis, flu-like diseases, or post-major surgery. So, as I said, it absorbs molecules between 5 to 55 kilodaltons. So it absorbs pancreatic enzymes, it absorbs bioglobin, free hemoglobin, certain toxins, certain pharmaceutical agents, and primarily both pro-inflammatory cytokines. It does not either remove albumin or it does not absorb immunoglobulin. So from that point of view, it is not detrimental to the patient. It can be set up with any system. CRRT, it can be either pre-filter or post-filter. Or ECMO machines. ECMO has been used quite extensively in this COVID crisis. So it can be used easily. It's very easy to attach in the ECMO circuit. I've used it several times. Cardiopulmonary bypass. It's very easy. You just take a side port from the post pump line here, and it goes back to the reservoir, venous reservoir. Or for hemoperfusion, again, it can be used as a monotherapy. So as I said, it is compatible with and very easy to use with any of the dialysis modalities. When to use it? Well, now this is the classic curve of pro and anti-inflammatory cytokines. The blue are the red are the pro-inflammatory cytokines, and the blue are the anti-inflammatory cytokines. This is where it balances out. So if you use it during this phase, it is too early. Maybe the patient may not need it. It may balance it out normally. If you use it here, it may be too late. Once the multi-organ system failures sets in, it may be too late to use it. Now, this is the right time B where you can use it. Coming to our Indian experience, well, I've had several publications on this. I'll just go in a little detail on these. So this was one of our earlier papers, heme absorption in the management of septic shock. This was a retrospective study of 100 single-center patient. And we had obviously IRB and ethics committee approval, and baseline characteristics of the patients, demographics and mean arterial pressure, vasopressor requirement. These are all septic patients. You looked at the severity score, Apache and SOFA, lab parameters, cytokine levels, and time of initiation. So we analyzed the detail. There were 100 patients, 40 were survivors, 60 were non-survivors. Demographically, well, the survivors had a little lower SOFA scores, little lower white counts and lactate levels. What did we find? Now, this is the survivors, significant reduction in vasopressor requirement and significant improvement in mean arterial pressure. In non-survivor, there was an increase in vasopressor requirement, not surprisingly, and there was a decrease in mean arterial pressure. Coming to the severity score, there was some reduction in the severity SOFA scores, pre and post, while there was no change in the severity score of non-survivors. Serum lactate levels, survivor group, significant fall in serum lactate levels, while significant increase in non-survivors. Cytokine levels in the survivors, all the patients had a significant reduction in cytokine levels and a maximally significant in IL-6 and IL-10. How did the timing of initiation affect the outcome? Well, if you used it within 48 hours, which is the blue part of the pie, 70% of the patients survive. If you use it after 48 hours, only 30% survive. If you used it within 2 days, there was a significant reduction in the hospital length of stay. So this particular study, in single center sepsis study, we found when you use the device, there was a significant reduction in vasopressor requirement in survivors, hemodynamic stabilization, improvement in the severity scores, and improvement in the lab parameters. And also, earlier we used it, better the outcome. But obviously, this requires a larger multi-center studies. And this was the same paper was presented in the annual big meeting, like your Avatar meeting, but bigger, in Brussels every year, intensive care and emergency medicine. I presented this paper. My second work was in cardiac patients, cardiac surgery, undergoing aortic surgery, major aortic surgery, not just valve replacement. Now, these are the patients who have a long pump time, they have major cytokine release, vasoplegia, and massive bleeding. So this was major aortic surgery, arch replacement, ascending arch replacement, and so on. So this was eight patients we used a control group, and 8 patients we used the device. These are mostly Bentol's procedures. And demographics were virtually comparable. And we measured cytokine levels at various time points, pre-cardiopulmonary bypass, 1 hour post, to next day and next day. What did we find? Significantly lower inflammatory cytokines and PCT, IL-6 and PCT in the patients in whom we use the device compared to the control group. Significantly, the mean arterial pressure was lower in the study group, but significantly better in the study group after the device was used at all time points. Duration of post-op ventilation significantly less in patients in whom we use the device. ICU and hospital length of stay both were significantly less in the study group. So we concluded from this that in patients undergoing major aortic surgery on cardiopulmonary bypass, cytosol use leads to significant reduction in IL-6 and PCT levels, higher mean arterial pressure with less norepinephrine requirements, better arterial oxygen partial pressure PF ratios, and shorter duration of mechanical and ICU stay. Then one of the problems which can be all encounter often in MODS is liver dysfunction and hyperbilirubinemia. So this was a patient, foreign patients for redo, that means third time surgery for valve replacement, and she went into multi-organ failure, high inotropes, liver failure. This was pre-cytosol, pre-beginning. This was while on it, and you can see how yellow it has turned. And there was a significant fall in bilirubin levels, significant improvement in liver functions, and the myoglobin levels also significantly fall. The patient was discharged to the floor. During this COVID-19 times, the awareness about cytokine storm, that is CRS, cytokine release syndrome, has significantly been conveyed to the doctors. So cytokine storm in the later part, after week to 10 days of beginning of COVID-19 sepsis, plays a very important role in outcome in these patients. So this was a review article we published in the Journal of Critical Care Medicine. So what did we find? So we have just published this series of cases, Journal of Medical Case Reports of patients in whom it was significantly beneficial to use cytosol device. Coming to other hospitals, this was a paper from in heart transplantation from Max Hospital. And this was a paper from, again, Max Parparganj. And they used it in septic patients. They found significant improvement in SOFA scores and reduction in PCT and leukocyte counts in whom they use the device. Now, when to start the cytosol therapy? Well, when the patient basically cannot be stabilized by conventional therapy. There's a clinical pictures of hyperinflammation, vasopressor requirement are going up significantly, there's signs of positive fluid balance and capillary leak, and there is a multi-organ failure happening. If you're measuring certain biomarkers, then PCT levels are going up, high IL-6 levels would indicate that this may help. In cardiac surgery, when you're expecting long cardiopulmonary bypass time, complicated surgery, redo surgeries, transplants, post-operative ECMO may be required. Pre-operatively, endocarditis is a very sick patient, high white count, organ dysfunction is already there, or again, LVADs and all that, or combined procedures. So these are the major high-risk cardiac surgical procedures. Post-operatively, you can use it if the patient is in vasoplegic shock requiring high doses of vasopressors, the signs of capillary leak and multi-organ failure, and PCT and IL-6 are high. That's the time to use it. Once you use it, when to stop using it? Well, that depends. If the patient treatment should be continued until stabilization. So if the first device has helped, patient is improving, you may use a second device. Or normalization of lactate levels has happened, then you may stop it. Organ failures are improving, vasopressors are almost off. After the first device, then you may not use a second device. So in order to validate all these findings, we have started in Cytodec an Indian registry where all the people who are using this device should register so we can collect the data. And there is a checklist which we have developed according to the disease severity, when to use it and when sort of not to use it. So if the score is 8 to 13, that should be the time to use it. Less than 8 is too early, less than 13 may be too late. So sepsis and many other critical conditions like trauma, burns, elicit cytokine response. Inflammatory cytokines can be detrimental to organ perfusion. Cytosol absorbs inflammatory cytokines, myoglobin, bilirubin, bile acids, and certain drugs. Cytosol use may improve survival, reduce ICU and hospital length of stay by reducing cytokines, PCT, vasopressor requirement, and organ function. Thank you very much for your attention.